Right. Anyway, I should say why I put up these criticisms. Yes, I'm telling you that health economics is a good thing and economic evaluation is a good idea and it can really help you perhaps with some quite tough decisions, but not everybody agrees. And so this is just one of the more prominent critics. If you actually follow the link, you find these criticisms and you'll find a rebuttal by some quite well-known health economists. So that's why I'm not going to bother taking each criticism and then say why this eminent editor is wrong. Right. However, I am very sensitive to the idea that some people might view health economics and economic evaluation as in some way unethical. There's something sort of almost wrong about it. You know, when we're deciding what treatments should be available, which groups should be treated, somehow looking at the costs and the benefits, it somehow just seems not quite right. And some people would go as far as to say unethical. And I think the reason for this is if you are going to do economic evaluation, if you are going to assess the costs, assess the benefits, the implication is you're prepared to deny some people treatment that they've got the capacity to benefit from. Otherwise, there's no point doing it. I mean, if you are comfortable providing any healthcare at all, so long as there's some evidence of effect, if you're comfortable doing that, you've no reason to do economic evaluation. So the implication of doing economic evaluation, the implication of weighing up the costs and the benefits, the implication is that you are prepared to sometimes say, no, we will not provide this treatment, even though we know these people would benefit from it. And that could seem unethical. The economist's response and my response would be sometimes we have to say no. It's not that we're It's not a simple case of just saying, well, we don't have enough money, let's get a bit more money, spend a bit more, and we can say yes. That might seem the solution. For the general public, when they see a decision not to provide a particular form of care, and part of the reasoning is on the basis of the cost, or possibly opportunity cost, when they see that, they think, well, look, we can always spend a bit more money. We're talking about people's lives. It just seems so wrong not to go and spend a bit more money. And so there's an idea sometimes that the problem is that the budget's a bit too small. If the budget was a bit bigger, we could then buy the healthcare and give people the benefit that in some sense they should have a right to. But it's much more fundamental than that. The need to ration, the need to prioritize is nothing to do with the budget being too small. It's more fundamental. Let me explain. There are many, many different ways we can improve people's health, or we can maintain their health, or we can prevent ill health. There are many different ways, some of which I've listed here. Obviously there's healthcare, but in addition to healthcare, there's things like improving sanitation, improving housing, increasing education and training, better nutrition, a cleaner environment, possibly things like a better work-life balance. We can go on and on. We can identify things that we could be doing as a society that would improve people's health, or, as I say, might prevent ill health. Healthcare and access to health services is only one element. Now that won't come as news to people working in a public health environment, obviously. But it's got some interesting implications. If we're trying to get the maximum improvement in health, and let's assume we are, we could debate whether that's desirable, but let's assume we are trying our best to improve health. If we're trying to get the maximum improvement, the way we do this is not by spending and spending and spending in one particular area, but instead we spend in the different areas. And we allocate our resources to education, to improving nutrition, to cleaning the environment. We allocate our resources so that the incremental benefit, the additional health that they provide in these different areas, is equal. That's how we get the most from a fixed budget, by allocating it so that the improvement in health, if you like, per pound spent or per million yen spent or whatever, that improvement is equal in the different areas of spending. You don't maximize health by putting all your resources into one area, for example, healthcare, and going on investing in healthcare until there's no incremental benefit. So you don't do everything that you can in healthcare that produces a positive benefit, because you'll do better if you stop spending on healthcare at some point and actually worry more about improving housing or improving the environment. And so my point here is, it's not just our budget's too small in a particular area of healthcare, and that's why we have to say no. Fundamentally, we should not go on spending in any area and on as the marginal benefit, the gain in health, goes down and down. We shouldn't push it to zero. We should actually stop spending in a particular area before that incremental benefit, that additional bit of health that's generated, before that reaches zero. And just to repeat, the reason we should do that is if you go on spending on healthcare right down till you're almost the gain is approaching zero, you're missing opportunities to improve health through other activity. So I would put it the other way around. Not that it's unethical to use economics and economic evaluation to inform decisions. I would say it's unethical not to consider the economic aspects. And this is because we're never going to have enough resources available to exhaust all the possibilities throughout the economy. So I'm including things like cleaning the environment, improving diets, improving education and understanding and knowledge, changing behaviour. We're not going to have enough resources to exploit all these opportunities throughout the economy. And so it's just not sensible to go on spending solely on healthcare so long as there's a positive incremental benefit. We do need to stop, and we do need to say no to some things. And also, even if we could exploit every opportunity to improve health, be it through healthcare, be it through additional investment in the environment, etc., we shouldn't do it. Because it's not just health that we're concerned about. Health's important, very important, but it's not the only thing that people care about. Some people care about, let's call it, national security or something like that. And other people particularly care about things like education. Salud. For example, should we only have educational programs if they're going to improve people's health? Clearly not. So there's more, sounds almost incorrect, but there's more to life than health. I do take the point, without health there's not so much life, but there is more to life than health. There's things that we value in life beyond just health. And so my final point here, or this is the final point from lecture 1, my final point at this point is economic evaluation is ethical because it recognises that the opportunity cost of treating one patient are the benefits foregone by other patients. The healthcare budget will always be limited and in some sense, too small. And so if we do more for one patient or one patient group, we're going to end up doing less for some other group. Now, I'm afraid that's life. That's how things are going to be, have always been, and always will be. So we have to recognize that and just be sure that when we do make a decision to expand perhaps treatment in one area, just convince ourselves that what we're gaining in terms of improved health is greater than what we're giving up elsewhere. And that's where economic evaluation comes in. It tries to help you identify if that's the case. Are you getting more benefit from the new activity than you're giving up elsewhere? And if you don't go through that process, I would argue that's acting unethically. So I would stand it on its head. I wouldn't say it's unethical to be thinking about costs and benefits. I would say it's unethical not to be thinking about costs and benefits. Any comment? Yes?
They are questions rather than comments.
Okay, yeah.
From your experience, governmental decision taking regarding the cost benefit stuff, is it only based on economic estimation or evaluation? Do they include the medical part? Or is the medical part basically included in the economic estimation completely?
Right, thank you for that question. What we're really looking at in economic evaluation, sometimes called cost effectiveness. The effectiveness, in this context, is the change in the patient's health. And so the medical part, as you refer to it, is a central part of this information. So it's not that we have economics and we have medicine, they're coming together. The effectiveness information is coming from, often it's from clinical trials, not always, because some things can't be subject to randomized trials, but it's coming from medical research, medical experience and knowledge, and that's feeding in to the economic calculation.
This leads to the next question. In the table you showed us about the estimated cost per tally gained by treating HCV.
Yes.
With suboxone. there is something I couldn't understand well. Maybe this table is very general for just to show us. There are more details to be considered, I guess, in this.
I'll try and find it. Sorry for flashing along. Yeah, I'm listening.
Well, I think there are more details to be
What's this?
considered.
Yeah.
Yes. There are more details to be considered in this estimation. I'm speaking from the medical point of view. I couldn't understand well the recommendation in case of genotype 3. In case of naive patients.
Yep.
Then there was recommendation to use the medication in case of cirrhosis.
Yeah.
From my little background on this kind of medication, I think it's not indicated for patients who have cirrhosis.
Yeah. That.
Or particular types of
Yeah.
cirrhosis.
With the new generation of directly acting antivirals, which sofosbuvir is one of, there is evidence of benefit in that group, and because they're further along, the bad things that are about to happen are much nearer in time, and so that's what makes it slightly more attractive to treat them. That was the view that was taken. Now another view is actually a far better group to treat vigorously and detect them and treat them are the intravenous drug users who are at a much earlier stage. They may still be asymptomatic, or they may have mild evidence of mild disease, and they are a much better bet because if you treat them successfully, you're going to reduce onward transmission. And don't want to give publicity for my own work, but I was one of the authors on a paper, came out last year, looking at this and arguing this, that there is a prevention benefit. It's not just a benefit to the health of the patient who's being treated, there's a prevention benefit, and if you take that prevention benefit into account, actually it's not these patients who are quite far down the pathway that it's most cost effective to treat. It's this earlier group. This calculation, interestingly, I'm glad you asked the question, this calculation and the appraisal done of the other related, lidisprevir, cimetprevir, there's a whole series of these drugs, they looked only at the benefit to the patient, and they didn't consider the benefit in terms of by treatment, successful treatment, to what extent do you reduce transmission and avoid other cases. So I think I would agree with you that once you recognise that, you would get more benefit from the no cirrhosis, the people at an earlier stage. So I agree with you. Where I disagree is the actual treatment is still of benefit. It's not sort of red. There was evidence of benefit for this group. I think that's just a product of these new treatments. But of course, they don't do anything for your cirrhosis. You just no longer HCV positive. You are still cirrhotic.
Sorry, another question. How about genotype 4, 5, and 6?
Right, 4, 5, and 6 at that stage. So this was decision making in about 2013, early 2014. At that stage, there was not a great deal of evidence in 4, 5, and 6, partly because in the country where at that stage were getting most of the evidence from, the United States, 4, 5, and 6 were much less common than in other parts of the world. It's now the case that we've got increasing evidence that also in 4, 5, and 6, particularly some of the combination therapies, so not just sofosbuvir by itself, but some of the new other therapies, even newer therapies, do work in 4, 5 and 6 as well.
But to my understanding, sofosbuvir cannot be used by its own. It has to be combined with...
Its initial license was in combination with pegylated interferon and ribavirin, or, excuse me, simply with ribavirin. Yeah. Subsequently, we've now got sofosbuvir with ladisbuvir and some other ones, and they are working also in genotype 4, 5 and 6. I should stress, this was an estimation done for decision making in England, so it's not so as I said in the previous slide, the pattern of genotypes is different across countries, and so what might, and also at that point in time, given medical knowledge, it was made. So that's how it was, that's why it seemed the right decision at that point in England. It's not an assertion that we should never use sofosbuvir in GT 456, but simply in England at the time, given the evidence, it did not appear to be a good use of resources.
Is it annual evaluation?
No, what happens is when a recommendation is made, as part of the guidance, right at the end, it says when the decision should be reviewed. Now, sometimes there will be a very early review date, possibly because you're expecting some big trial to report or something like that. Other times, it might be quite routinely, say, about a 3-year review date. That varies. I can't remember the specifics for this one. Okay, not at all. Yes?
I have a question about the ethical question. In Japan, from last year, they introduced the cost effectiveness assessment for the new drugs approval, and that there is a fixed proportion of the insurance that's from the government and from the individual. I just wonder that if some new drug is very sensitive to a very small population, but the government, when they assess the cost effectiveness, they may think about this drug is not so cost effective. They may don't approve this drug to be used in Japan. But I know only a little about in England. There is a different proportion when they consider about the cost effectiveness of the drugs. So I'm not sure whether it will be better to approve the new drugs to use in England. Will be quicker and will be more options.
Right. I think there's a few points in there. There's a category of drugs or treatments that's sometimes known as orphan drugs or orphan treatments, and so indeed sometimes have things called ultra-orphan, where the number of patients is really very small. And health economics is not saying you must always be guided just by the cost per quality and there aren't other factors to take into account. Now, so for example, NICE, there's a body here that's making these decisions. The appraisal committee, which I've been a member of for coming up for 14 years now, the appraisal committee does look closely at the evidence for cost effectiveness, but it's not a mechanistic decision. You know, if the number is this, we say yes. If it's that, we say no. There's other factors to take into account. And so, for example, you might want to take into account the rarity of a condition, because there will be a tendency for some of these treatments for a particularly rare condition, a tendency for it to be even more expensive, partly because some of the costs of drug development are largely fixed, and then these costs are being borne by a smaller market because of fewer patients. And you may well feel that it's somehow unfortunate or unfair to not recognize that, and you might want to do something about it. And indeed, in the United States and in England and the rest of Europe, I don't know about Japan, orphan treatments are given a sort of more favourable treatment in terms of allowable for tax, reducing the tax burden on the manufacturer. That if the development cost is going into orphan treatments, they're treated a bit more favourably than our research and development costs incurred for other treatments. So there's some recognition that if we don't provide some additional encouragement or incentive, that there won't be enough investment in these treatments for smaller patient groups. So that does happen. A body like the NICE Appraisal Committee can, if it so wishes, decide that it wants to treat one area more favourably than another. I'll give you an example. There's a drug called pemetrexed, which is partly a treatment for lung cancer, but also a treatment for mesothelioma. Now, mesothelioma is a disease which is brought about by exposure to asbestos. And many people back in time, at least in England, back in time, worked in industries that used quite a lot of asbestos. There wasn't a great awareness of the potential dangers, and so many people working in these industries got exposed to asbestos and subsequently have had major health problems, one of them being mesothelioma. So when NICE was looking at pemetrexed for mesothelioma, we looked at how well a drug works. I must say the evidence is not great, but it does some positive evidence. We looked at the cost, and if I recall, the cost per QALY was coming out at about 38,000 or something like that. Now back then, that was a time when we were tending to accept things maybe around about 25,000, or we're beginning to go up to £30,000, but 38,000 would have appeared too high. Why spend 38,000 here to get a QALY if we can spend less money somewhere else to get a QALY and get more health? And we still approved it. We said yes. And the driver there was this feeling that it was relevant consideration. One, mesothelioma is a very unpleasant disease. Two, there are, well, pemetrexed then, and probably still is, about the only treatment that shows effect. And three, these people, this patient group, largely had the condition not through any fault of their own, but through their occupation. And those circumstances taken together led the committee to say yes. And so you could do the same thing with some drugs that are to treat exceptionally rare conditions. So there's no sort of rule. There's no rule present here that says if it's more than £30,000 per QALY, or pick a number, it's no. You're weighing up different circumstances. Or put it another way, maybe not all QALYs are worth the same. So I will say a little bit more about QALY at some point, but there's this measure of health gain, the quality adjusted life year, and the great strength of it is potentially you can use it in lots of different areas. So it's not a condition-specific measure, it's more generic. But maybe not all QALYs are worth the same. Some QALYs are more valuable than others. And in effect, a decision that says yes to pemetrexed for mesothelioma is saying that quality gain we get in that patient group, we value a bit more highly, partly because it's such an unpleasant condition and partly because it was brought on by exposure which the patients had no choice in. I don't know if that addresses your question.
Thank you.
I think the takeaway point there is, if it was sort of mechanistic, if it was simply, we do the sums and the numbers above a line or below a line and you've got a decision, well, all you need is a sort of, I would say a big computer, probably not even a very big computer. You just need people checking the numbers, feeding the information in, out comes the answer. That's not how the decision making's done. How it's done is a committee taking quite a lot of time to review the evidence partly produced by the manufacturer, evidence, a lot of it clinical evidence, looking at that very carefully and deciding, on balance, does this look a good use of resources for the NHS in England or not? So it's not mechanistic. But, having said that, cost per quality remains a very important input because that is signalling to you how well this treatment performs compared to other ways you could spend the money elsewhere in the health service. Okay. Yes?
You just said not all quality values the same. But who judge it? Who assess it?
Right.
Which quality values more?
Right. In this context, it's a particular committee that is making that judgment. It's made up of a range of individuals, many of them from a clinical background, some from the health services, more on management side, some of it more, I tend to say technical, but technical evaluation sense, statistician, health economist, a range of skills and background, and some lay individuals, lay persons. So it's a broad range of individuals.
So it's quite complicated.
The individual decisions are quite complicated, but the process, excuse me, the process, well, I suppose the process could seem complicated. I mean, I've been doing it so long that it doesn't seem complicated, but there's a very detailed process by which manufacturers engage and produce information. That information is dealt with on a particular time scale. There's something called a reference case. There's a sort of standard approach that they're expected to follow, but they can also bring in additional information. So that, in that sense, that's sort of complex. But the real complexity comes when, on an individual decision, trying to weigh up these factors which may go beyond just the cost and the quality. And of course, these costs and these qualities are uncertain. And that's not a product of the economics, that's a product often of the medicine and the clinical trial information that's available. What might seem a simple question like, if we use this drug, how much of it will we use per patient on average? We don't know. Because there's a distribution in time to treatment discontinuation. We can see that in the trial, but we fully know that if you then take that and do it in routine practice, you might get quite a different pattern of time to treatment discontinuation. You might get a different estimate of how much drug is used. So there's lots of uncertainties. And so I guess it is complex in one sense. You've got to interpret a range of evidence which is quite sometimes sophisticated evidence. Trials themselves can sometimes be hard to interpret. The economic model can be quite complicated sometimes. And then you've got the other sort of factors that you might want to take into account. We are encouraged in these committees, this is a directive from government, to bear in mind how innovative the treatment is. And specifically, are there benefits of this treatment, because it's innovative, that are not captured in the cost per QALY? Now that can be quite a tricky one. As I said, well, for example, sometimes you're comparing taking a tablet with a subcutaneous injection. Sometimes you're comparing a daily treatment with once every 4 weeks. Now, we can see how perhaps a tablet might, for most people, be preferred to subcutaneous injection. Similarly, a subcutaneous injection is probably preferred to an infusion. We can see how treatment once a month might be better than daily treatment. But what value should you put on that? So it is complex, yeah.
So as you say, it's complex and the cost-effective analysis, how much in the whole decision making?
Well, I guess I think what I'm saying is that the cost effectiveness information is a central part of the decision making, but it's not by itself what leads to the decision. Yeah, I think that's how I would summarize it. Okay. Okay. I'm sure there will be continuing opportunities to ask questions. Where is this picture? Give you a hint, it's in Japan. It's a temple just beside the Tokyo Tower, you know, that red and white one. What's this got to do with social capital and the measurement of social capital? Well, as we'll find out in the rest of the lecture, attempts to measure social capital end up sort of being things like counting proportion of people who belong to particular organizations, or things like religious groups, counting how often people go to a meeting. It's counting and counting and counting. And I guess this is a Buddhist temple, excuse my ignorance, but it probably is. More temples, more social capital? I don't know. Or more people participating with these beliefs, more social capital. That's what runs through most of the social capital literature. And, well, you know, do I count these? Well, does that give me a measure of social capital? Well, quite clearly, well, I'm about to say quite clearly not. But look, individuals have come along, they've knitted a little cap for that, they've put these things that go around in the wind, I don't know what you call them. If there's only one, maybe it's just one individual that's shown any interest and come along, but there's loads of them. So maybe this is a measure of social capital and greater engagement. Well, I don't know. What we're going to get to is a series of questions at the end. Partly, what is social capital? How can we measure it? And can we measure it reliably or robustly? But yeah, I have to say that, of course, I took this photo before I knew, I'm not psychic, before I knew I was coming to give a lecture on social capital. This was back in, 2 years ago. 2 years ago, okay. Right, lecture 2. Excuse me. So, what is social capital? This would seem a simple question, but it's far from straightforward to answer. It is not as simple as it appears. I've got a quote here from a statistician in England. Social capital can end up meaning all things to all people. And that might be going a bit too far, but it is a bit like that. it's almost anything can be described as social capital, as we'll find. UK formally follows a OECD definition, and that OECD definition focuses on networks together with shared norms, values and understandings that facilitate cooperation within or among groups. Now, immediately you sense how general that is. Part of it, networks. Well, we can imagine what a network is, but a lot of networks are not particularly visible. They exist, but they're not visible. Shared norms, shared values, shared understandings. Well, that's really quite hard to measure. When is an understanding shared between people? How can you sense it's shared? I, as an outsider to Japan, have a sort of feeling that maybe in Japanese society there's particularly strong shared norms. Now this is all, I have to say, this is all based on having a Japanese wife. So it's not very good science. She's a very good wife, but it's not good science as a means of trying to make these generalizations. But that is my sense, that there's a very sort of strong sharing of norms, or much stronger than in, say, England, sharing of values and norms. There's various distinctions that are made, and I'll go through some of them. Sometimes the distinction is drawn between individual social capital and community social capital. So we'll look at that one. Another distinction that's sometimes made is between cognitive components of social capital and structural components. We'll look at that. And yet another one is between what's called bonding social capital and bridging social capital. Indeed, there's other forms. There's one called linking social capital, but I'm not going to go into that one. So I want to explore some of these different forms of social capital. Taking the individual and community one first of all, it's quite common for a distinction to be made. So individual social capital can be defined as the level of trust or group working or membership or cooperation that the individual has with the larger society. So it's focused on the individual and what is their relationship to the broader society. This can be distinguished from the community social capital, which is talking about the extent, the density of trust, of cooperation, of the various links and activities within a given population. So it's not looking at it from the individual's point of view, it's looking at the whole population, almost looking down on it and looking at the degree of activity. I don't know if it helps, but what comes to my mind is, have you ever seen these pictures or really graphics of flight paths of aircraft? And so if you had a map for Japan, there'd be a big thick line going into Narita. Possibly even thicker, depends how you measure it, by flights or passenger numbers, into Haneda. But then the line going into Itami would be a bit smaller, and so on. And that would be measuring the number of flights or maybe the number of passengers taking that route over time. And so that would be a bit like the community social capital. You're looking at the extent of travel into different airports. But for the individual, of course, we don't look at it that way. We think of our relationship to different places. So then for the individual, I suppose the counterpart would be that particular flight that on one occasion or every week they take from one airport to another. So I don't know if that helps, but that's the distinction from the individual point of view and the overall community point of view. Now, there is a question here. Can we estimate the extent of community social capital by looking at the data for individual social capital. Is the community social capital just the summation or aggregate of the individual social capital? And we'll come back to this, but part of me thinks, isn't there something there that's not just the individuals added together? There's a sort of, maybe it's a synergy, but there's something else created, and that's the community element. Here's one index of community social capital that's quite widely used. I believe he's a political scientist, Putnam, and he identified, I think it's 14. I better check, do my sums quickly. Yeah, I think it's 14 elements. And he was saying that if you measure each of these things, you'll have a good idea of the extent of community social capital. Now, some of these things are characteristics of the community. So for example, this is back to our, how many temples have you got in Tokyo or something? Civic or social organizations, possibly religious organizations, per 1,000 population. Or another one, number of non-profit organizations per 1,000 population. Or, and it seems a bit of a jump, turnout in presidential elections. But you can see how you could characterize a community with one of these measures. So, in principle, in Kyoto, we could ask how many non-profit organizations are there, and we could divide by the overall population, and we get an estimate per 1,000. You could do the same for Nagasaki, do the same for, I'll run out of Japanese cities in a minute, Yokohama or something. You could do that calculation. So you could see that you could certainly, it's something measurable, you could use it to characterize a particular locality. Similarly, in principle, I guess, you could say what the turnout, you don't have presidential elections, Putnam's writing in a US context, you have prime ministers, I guess. It is a prime minister. My woeful ignorance of Japanese politics. I saw him on television this morning. He was having to interact with President Trump. Anyway, turnout in presidential elections. So was the turnout 45% or was it 65%? So if it's 65%, is that twice as much social capital as 32.5%? So those are characteristics of the community. Another set of his elements in his index are to do with the individual's participation. And so the question would be, for an individual, did they attend any public meetings in the past year? Have they served on the committee of a local organisation? If they did attend club meetings, if they're a member of some club, how many did they go to? And so on. How many times in the last year did the individual volunteer their services? Or even, last one in that particular section, the mean number of times the person entertained at home in the last year. Now, I've got a very small flat, and it makes entertaining at home rather difficult. So, have I got less social capital because I've got such a small flat? Maybe. And then the final one, I've in that first column, it's my description, so I'm sorry, whoop, keep pressing the wrong one. Characteristics of the community, individual participation. Call this one individuals' beliefs. The bottom two probably are beliefs. I'm not sure if the first one's a belief. Individuals are asked, do they agree with the statement, I spend a lot of time visiting friends? And the idea being, if you strongly agree with that, that's more social capital than if you disagree or strongly disagree. really the most common measure, I'll come to you in a second, is about trust. And the question that's asked again and again in lots of national surveys in lots of countries is, do you agree with the statement, most people can be trusted?
I try to use this social capital scale to a group of people with disabilities. And I consulted with a person who is blind, and he commented me through the email that when I asked those individuals' participation scales, he told me that the mean number of club members attended in the last year. He asked me whether I was talking about the face-to-face meeting or because he told me that he has attended so many meetings over the internet.
Yeah, that's a good point. This has evolved really particularly in the 90s into early 2000s at a time when internet was very young. It's strange, I can't remember when I first sent an email. I just don't know. I must have been quite excited. Will this work? Things have changed. And so I think you raised two issues there, really. I mean, one is the technology is changing, and now I can't imagine an up-to-date list is going to have to sort of Facebook, etc., or its equivalent. It's got to recognise that there's many, many ways of participating. And it's argued that maybe in certain elections in recent years, social media has played a much bigger role than all the traditional forms of political engagement. The other thing I think you raise is the issue, for disability is an interesting question. To what extent are some of these questions almost sort of, not discriminatory, but they sort of, you have to calibrate. Does somebody identify with belonging to a disability group or not? And then, if you're going to ask the same questions, the answers mean a different thing. Because possibly the effort involved, not internet, but other forms of participation, for someone belonging to a disability group, might be hugely greater than someone not. And so if you then just treat it 3 times per year and you just don't calibrate, you're understating or misstating what it represents in terms possibly of participation in social capital.
So I have an answer to this person who is blind, whether meeting someone on the virtual world is the same as meeting in person. So what would be your suggestion?
Well, there's definitely evidence that many people are more willing to answer questions about themselves on the telephone or maybe give information on the internet compared to if they've got somebody in front of them. Somehow they're just willing to disclose more because of the sort of anonymity. Now, does that mean that participation in online meetings is different from participation in a face-to-face meeting? It probably does. Does it mean it's less social capital? I'm not sure. I guess on an internet meeting, you're potentially meeting lots more people. Because face-to-face, there's only so many people can sort of take part in that conversation, but online, many, many more. So I don't know the answer. I think my answer is it's different, but I'm not sure in what way.
I think he was asking for the specific item that is serving as an officer. So that group is selected. It's not open for everyone.
Mm-hmm.
But because of their disabilities, meeting face to face became is not easy. So they decided to have a office meeting on the internet.
Mm-hmm.
So he asked me if the virtual world is the same as meeting on face-to-face basis. So I have an answer to hear this question.
Well, I don't know the answer. I'm willing to say I can see it's different, I think, but I'm not sure in what ways it's different.
Because the number could vary.
Mhm.
Say, yes, you can count a virtual meeting as a meeting.
Yes. Oh, yes, you can get different numbers, definitely. I mean, one view of it might be, oh, well, internet meeting is that much easier, so they don't count as highly. That might be a view. But then the other side of it is this issue of calibration, I was suggesting, that for somebody, a member of a disability group, you've got to do the calibration the other direction. Because participation might be harder, one meeting isn't equivalent one-to-one. So I think it goes in both directions. So interesting question. I don't know the answer to it. Thank you. So, but this is a widely used one. I have difficulty answering some of them. Most people can be trusted. In what way am I trusting these people? Am I trusting them to not steal from me? Am I trusting them if I marry them, they won't cheat on me? By the way, that choice is just nothing, not non-personal. I'm trusting them that they won't take advantage of me in any way. What does it mean to say I trust someone? Most people are honest. Well, how honest does somebody have to be honest? Does this mean 100% honest? So I think it's all quite problematic, some of these. Let's look at this distinction between cognitive and structural components. And the cognitive part of social capital, it's suggested, is to do with these shared norms, attitudes, values, beliefs. For example, one we've just been looking at, that most people can be trusted. That's seen as cognitive social capital. That's contrasted with the structural social capital, which are these observable elements. The numbers of organizations, the numbers of members, the numbers of meetings people attend. Then we can make that distinction, but you can quite clearly see that the cognitive and the structural parts are so interrelated. Because if you have high cognitive social capital, you're more likely to engage with other people. You're probably more likely to join organizations because you trust people. You trust them. And the reverse. If you don't have structural social capital, if you don't join groups, if you don't attend meetings, you've got less opportunity to develop trust in people because you're seeing a much smaller group. Maybe you're not really going outside your family. And so the outside people are much easier to not trust because you don't know them, you haven't met them. And so you can see how lower participation may reduce your cognitive social capital. What about this bonding and bridging social capital? This is a very widely used distinction. But if you read about it, it's made in two different ways. Sometimes the distinction between bonding and bridging, it refers to the identity of the participants, the identity, and sometimes the emphasis is about the gains from social capital. Let's take the first one. The idea is that bonding social capital refers to family and friends. And so it's the relationship between family and friends. These are closer bonds. And that can be contrasted with much looser arrangements you have with other people, like colleagues at work, or neighbours, people living in your vicinity, or if you're a member of some club or group, relationship with these other members. And that's seen as bridging social capital. It's a sort of linking outwards and making relationships with people beyond your usual group. But we also see that distinction between bonding and bridging, sometimes in question of the gains from social capital. So with the bonding social capital, all the benefits to that are within the group. They're within the family. And that can be contrasted with the bridging social capital, where it's relationships outside the group, and the benefits of that are potentially enjoyed by a much wider range of people. So that there'll be people who are not part of that network, but they still benefit from there being more social capital out there. So it's a sort of, well, in economics, we'll come on to this I think on Monday, we have something called an externality or external effect. And so the existence of all these organisations that I might not be a part of, but the existence of them adds to social capital, and I benefit from that. Now that's a contrast from the bonding one, the within family, where you have to be in the family to benefit from the cooperation within the family. But this bridging one, the fact that there are these networks of individuals, people participating, cooperating together, produces a general benefit that everybody can share in. Let's see. Yeah, I mean, standard example of externality in economics might be things like air pollution. Now, if a factory doesn't produce so much waste product, and it's as a part of its production process, the workers in that factory will benefit from that. They're not inhaling so many fumes and so on. But actually, everybody outside who shares in the environment is also benefiting from the factory not producing so much waste product. So that's an externality. So I think that's quite an interesting one, this way of looking at it. That you begin to get a sense of where the community social capital might differ from individual social capital. You don't necessarily have to be part of the organisation. In this case, you don't have to be part of the family to get the benefits. Just being in the community, if there is more social capital in the community, there's a sort of another word for externality is spillover effect. There's a benefit like that. And that's what makes me ask the earlier question, can we really identify community social capital just by adding up the individual elements? Maybe there's something greater than the individual elements. Now, in most countries, and here I'm going to speak for England, or actually, it's a difficult distinction between United Kingdom and England. As you'll know, United Kingdom, it's 4 countries. England, 1 country, just so happens it's the biggest. Oops, sorry. And some things we do on a UK basis, and some things we do on a country-by-country basis. And I have to say, I don't know if the Office for National Statistics responsibility is UK-wide. I think it is. But apologies for that. But maybe you don't have to worry about it. There's this sort of place in Western Europe that's largely England, but it's more than just England, it's United Kingdom. And we have a national body for collecting statistics. It's a sort of arm's length agency. And it's responsible for collecting, analysing and disseminating statistics. And these statistics are not just about the economy, but they're about society, they're about the population as a whole. And for a number of years, they, as really growing out of an OECD initiative, they have been reporting 23 individual measures that are thought to be indicative in this context of national well-being, but it's an alternative language for social capital. And I think it's quite interesting to look at these. They cover 4 domains. One element's the personal relationships, another is social network support, then something called civil engagement, and then finally the trust and cooperation norms. And I suppose the key feature of these measures is that they're almost entirely based on questions that are being asked anyway as parts of various surveys. And thus, the additional effort of sort of putting the information together is not great. So it's not that we're specifically asking a new set of questions each year. It's in this context, we're taking advantage of different ongoing surveys. So for example, there's something called the European Social Survey, which takes place in the separate countries of Europe, but a standardised set of questions. There's something in UK called Understanding Society, and that's a longitudinal household survey. And then for England, there's something called a crime survey, where we're finding out about people's perception of crime. And so the key feature here is these bits of information are being collected anyway, but then they're being put together in a sort of measure of national well-being. Also, the other feature is, and this is obviously true of all the sort of social capital elements, although the concepts may be rather general and hard to define, the measures, of course, they're all countable things. You know, what was the percentage of people voting in an election? How many non-profit organisations are there in a particular locality? They're all highly measurable. So let's look at these. As I say, 4 domains or 4 different aspects. So the personal relationship aspect is all about, as individuals, who do we know and what do we do to establish relationships with individuals and maintain them. Social network support is partly who might help us if we need additional help, but also the other side of it is what can we and what do we do for others. So the sort of two-way thing there. The civic engagement is things like political participation, things like volunteer activities, various forms of community action. You might once a year clean up your neighbourhood. 10 of you get together and get probably doesn't happen in Japan, but supermarket trolleys, do they ever get thrown into water courses? They just wouldn't happen in Japan. But in England, it's sort of seen as entertaining to throw a supermarket trolley in a canal or whatever. So you might, as a group, get together and say, right, we're going to clean this stretch of canal. Things like that. That would be a community action. And the final category is trust and values that are beneficial to society as a whole. Beneficial because with trust, it's easier to cooperate. And the idea is the more cooperation we have, the more benefit we get. So let's just look at some of these figures. Now, of course, I'm sure some of these questions are also asked in Japan, and it's been very enlightening to put the percentage response for Japan alongside. Unfortunately, my Japanese is not up to it, but you might like to consider to what extent you're surprised by these percentages. or not. So the first one's to do with personal relationships. I almost feel sad just reading the first one. Proportion of people who have at least one close friend. 97%. I thought that was high, actually. But anyway. Proportion of people who meet socially with friends, relatives or work colleagues at least once a week. Quite high, 61%. Feelings of loneliness often or always. Now remember, we're trying to measure here, or we're claiming to measure social capital. But to what extent is feelings of loneliness often and always, is that really social capital? Or is it, I mean, that could be an aspect of mental health and so on.
So how to define often or always, how to define frequency?
I don't believe they specify it. They leave it to the individual to interpret often or always. Well, always is always, I guess. But often, I agree, I'm not quite sure. I have no idea. If I was responding to that question, well, I'm not often lonely. So I can't, I'm never lonely. So I can't, I haven't a clue what goes into people's heads. It's a good point. You know, this information, if we're going to interpret it, we have to sort of have some understanding or view about what people think when they're completing these questions. So I don't know about often, sorry. Proportion of people who've used the internet for social networking in the last 3 months. And the final one, proportion of people who regularly stop and talk with people in the neighbourhood. That's quite an interesting one, because you know the way modern world goes, particularly in some countries, in some cities, you're almost not encouraged to talk, stop and talk. Anyway, that's 68%. But just keep it in mind, these things, which in principle are sort of measurable, because they're questions you can ask and people will give you an answer. The idea is, hardly needs to be said, the higher these are, apart from this one, the lower this one is, that's indicative of more social capital. Support networks. Percentage of people that have a spouse or partner, family member or friend to rely on a lot if they have a serious problem. I find this quite encouraging. So this is the figure for, it was probably UK-wide, this one, 84%. Proportion of parents who regularly receive or give practical or financial help from or to a child aged 16 or over, not living with them. Well, you can see what it's getting at, you know. You had a child, they're now grown up a bit, they're not living with you. To what extent are they helping you, are you helping them? But is that really something to do with social capital? Again, it's difficult. Proportion of people who borrow things and exchange favours with their neighbours, 42%. Presumably it's a part of the 68 in the previous one who spoke to their neighbours. Civic engagement. Volunteering. Now, proportion of people who volunteered more than once in the last 12 months. So this could be 19% just volunteered once, but this 19% might have been doing it every month. So it's quite possibly insensitive measure. I guess the people who are more supportive of these measures will emphasize they're asking the same questions of broadly the same people year after year. And so it's not the sort of 19% that matters here. It's how does that compare to previous years? And it's not one measure at a time. It's, is there a trend across most measures of increasing or decreasing social capital? Voter turnout in the general election. This won't work in Australia. In Australia, you get fined if you don't vote. Is it voluntary in Japan? Yeah. Proportion of people who have been involved in at least one political action in the previous 12 months. What's that? Theresa May comes on the screen and I say something, oh, that wonderful woman, or the opposite. Is that a political action? Now this is almost the politicians want to know how popular they are. Proportion of people who are very or quite interested in politics. I'm surprised it's 56% in Britain. It's only just below the election turnout. This is very or quite interested. Anyway, and the final group was this trust and cooperative norms. I like this one. Percentage of those who have trust in the national government, 35%. Now I'm quite sure it must be higher in Japan. Proportion of people who would say that most people can be trusted, I don't think it was a typo, I think I double checked it, I think it's also 35%. But an interesting one here, proportion of people who say that most people in their neighbourhood can be trusted. And it comes back to this thing, if you're in a neighbourhood, you almost are taking part because you proximity, and so you sort of know people regardless. Other things, you have to step outside to get to know them. And so we don't trust people in general, but people in our neighbourhood, because of the proximity and that opportunity for trust to develop, we trust them much more. Proportion of people who definitely agree or tend to agree that their local area is a place where people from different backgrounds get on well together. I found this very encouraging, and it sits very uncomfortably with a vote for Brexit. So 89% of people definitely agree or tend to agree that they're local places where different people from different backgrounds get on together. So why on earth do a majority vote essentially for much more restrictive immigration policies? Then we get on to sort of crime one here. Do you feel it's fairly safe or very safe walking alone after dark? And then we've got a male-female answers. That's a bit worrying, but that again, remember this is UK. I'm anticipating in Japan this would be higher, the same?
Higher.
Yeah. So you get the flavour of it. Now there's different ways of asking these questions, there's different questions you can ask, but virtually all measures of social capital fall into this sort of category. They're either asking people about their beliefs, or they're asking about their participation in groups or networks. And sometimes that might be within the family, sometimes it might be neighbourhood, sometimes it might be more broadly. Now, that's what gets me in my questions. By the way, I'm not claiming copyright in this character, Tintin. I took a photo of a poster. Yeah, that would be criminal to claim I've invented this character. He's a Belgian creation, Hergé, and yes, now popularised in films as well as cartoons and books. So questions. Is there a single unifying concept of social capital? Well, if you read the social capital literature, you come across the same ideas again and again. You know, individual social capital, community social capital, this bonding and bridging, to some extent the cognitive and structural. You come across it again and again. When it comes to specific measures, way the most popular are things about trust, but not just that. And then there's all these questions about participating, voluntary participation, how many groups are you a member of, how often do you go to meetings, whether you're an office holder in these groups. So there's a sort of, the thing that's unified is it's the same measures coming up again and again. Where my question mark is there some sort of concept that we're measuring? Or are we measuring lots of different things? That's one question. To what extent do these survey questions, possibly regarding people's beliefs or their behaviour, to what extent are they like to be a robust measure of social capital? Now, I do want to stress that sometimes these measures are simply being used as a snapshot over time, and the issue is what direction are things going in? Is more trust about or less, and so on. The Putnam, who's popularised a huge amount of this, had a very famous book called Bowling Alone. And the idea was his observation that, this is 10-pin bowling, his observation that bowling was very, very, very popular in the United States, but something had changed over time. And what had changed was it used to be bowling clubs, and people were members of clubs and they met together. But over time, that had decreased hugely, and individuals, or maybe not just solely by themselves, but in smaller groups, but not formal groups, not clubs, were doing their bowling outside of clubs, but still bowling was popular. And his interpretation of this as a political scientist was actually there's a lot more going on than, it's not just about bowling. There's some trends in American society that were leading to less participation, less engagement in civic events, less engagement in political activity, and so on. Now the question is, you know, by measuring these things, are we, how confident are we that we're capturing this thing called social capital? I guess what I should say is, I probably should have said at the outset, why on earth do we worry about this? And to some extent we'll come to this on Monday's lecture. There's a view that the amount of social capital could have important effects, more social capital, generally beneficial effects, less social capital, possibly harmful effects on people's health, but not just health, on how well the economy works, and all sorts of aspects of life. Because we are social animals, we don't exist, well, we exist as individuals, but we are working together to some extent, we are cooperating. And the more cooperation we've got, the more we're willing and able to trust in each other, the more we can achieve. Whether that be with respect to people's health, or that just be with respect to economic development. I should maybe say that at the outset, but we'll come back to that on Monday. So what do you think? Do you feel that there is something, well, there's obviously something called social capital because people write about it. And so it exists. But do you feel it doesn't exist because people write about it, it is there? I'm expecting lots of yeses. Don't you think it exists? Do you think it's a sort of figment of sociologists, political scientists, psychologists, economists' imagination?
I have a small comment. Yes, I believe it exists, but I don't think that what is going on right now for measurement is enough.
Mm-hmm.
I mean, when we think about measurement, it means quantifying, like numbers.
Mm-hmm.
And these kind of questions are quite vague. So, but I think the impact on other measurable outcomes can be measured. So I'm looking forward to Monday's lecture.
Right, that's an interesting statement. So this is not particularly measurable, but the impact is measurable. But in order to associate the impact with the social capital, don't you have to be able to measure the social capital?
At least for now, I think it's not enough. I don't know.
Okay, yeah. Please.
Is there a way of validating the measurement, the tools which are being used?
Well, there's various things you could do. If you believe these are tapping into something called social capital, one might imagine that they should tend to move together, up or down. Not absolutely systematically all together, but it would be strange if some things are going up and some things are going down because you're saying these are part of social capital. So it might be as evidence, it's a sort of, some sort of validation. You would expect correlations and maybe the changes in these measures to be correlated, to tend to go in the same direction. I think that might be fair enough. The other thing you could do, and this again anticipating a bit about Monday, is you could say, right, I'll say this is a measure of social capital. I'll look at to what extent it seems to be related to other things, such as health outcomes, and I'll control for other things. So I'll try and isolate the effect of this thing called social capital. And if you then could have hypotheses, we don't expect more social capital to damage people's health. You're tired from going to so many meetings. I don't think so. So that would be another way of doing it. So one, you could kind of look at to what extent these measures move together, and another, you could try and relate these measures to some other outcome, and for us, the most interesting outcomes are probably in terms of health. And you'd be looking for some evidence that higher levels of social capital are associated with better health outcomes.
I think I've answered some questionnaires regarding these questions, and I didn't know why I was being asked this kind of question, so now I understand.
Ah, right. Why was somebody asking you? Why are you asking this? Yeah. Well, yeah.
I thought some of the questions were not about specific or difficult to answer.
Mm-hmm. Yeah. That's probably why you're being asked them. Yeah. Other views? Yes.
It's my first time the idea of social capital in health economics is today is I first hear this conception, and what comes to my mind is that social capital is some kind of resources. So some resource and the capital, the social capital and the economics is using the economic tool to evaluate or to evaluating the impact of social capital in health areas. Maybe I don't know what the social capital and the economics combined will, what kind of effect will come on. But this is my ideas.
Okay, right. Well, I'll introduce some of the evidence from the economic perspective on Monday. It's actually the case that some economists have been quite critical of calling whatever this is social capital, because capital has, traditional view of capital in economics is things like factories and machines and maybe technology as capital, resource that can then be utilised with other functions. There is also, for a number of years in economics, the idea of human capital, and that's where we begin to look at the individual, I think quite wrongly, but look at the individual essentially as a machine. And when the machine's broken, or the individual's ill, if we can mend the machine or cure the individual, the machine can work again, and so can the individual. We return them to productivity. Now, that sort of way of thinking was never very popular in economics, but over the years has got less popular. Although having said that, it's a human capital notion that largely lies behind the notion of a DALY, Disability Adjusted Life Year. Or originally it was very much based on a human capital notion. The DALY had an age weighting, so that at the very young age essentially had no weight. The weight attached to the disability or preventing disability rose as people got to their more productive years. They got to an age where they had more people dependent on them, either younger or older people, and then the weight began to fall again as they got older. So the DALY originally came from very much a human capital notion, but the rest of economics has largely doesn't really embrace human capital as a good analogy. But some economists would argue, and social capital is something else altogether, and it's nothing to do with capital. And so it's not a useful analogy, they would say. So maybe you're seeing the word capital and then feeling, how does this fit in? But that's the word we've got. This is what happens. You get a term for something, and then it's very difficult to move away from that term, because that's the language that everyone's using. To what extent do you think these sorts of elements, sorts of things I've outlined, things like trust and so on, and participation in organisations, to what extent do you think it does measure, let's call it social capital, it measures this thing? Yes?
Thank you, Professor. I think it's a very interesting topic. And actually, I guess social capital is quite versatile in different countries with different social culture and different environments. So I guess that what have learned today, we may have a basic principle. We measure it from the individual level, community level, even national level. So I find it's very interesting. I'm considering how to measure it in China.
Mm-hmm.
Yes. And also, I just get social capital. This word is quite, maybe we are talking about some general social capital. And maybe we have some social capital related to health, social capital related to education, even science. So maybe in different items, I guess. I'm looking forward to the
Right,
lectures.
I see. So that raises a very interesting possibility. We could have something called social capital, which has impact in different areas. One area of impact be it might affect health outcomes.
Yes.
But what you also raise is the possibility that there isn't just one type of social capital, and the social capital that's relevant for health
Yes.
might be different from the social capital that's relevant for education.
Yes, maybe.
Mm-hmm. That's true. I mean, for example, just thinking on my feet, for education, one of the most important things, I guess, is almost belief in the future. Because why invest in yourself? Why make the sacrifices now to gain more education? Well, economists sometimes call education an investment good and a consumption good. So you could just do more education because you enjoy it. But there's a strong investment motive, I think, for most individuals, that you are having just rubbish the notion of human capital. You are building up your capital stock with more education. The real benefit, a large part of the benefit, will only be in the future. The opportunities it gives you in the future. Now, so in order to encourage individuals to take up more education, you want to make the future look more assured or more available to them. Now that might be different from health. Maybe the payback in health is more immediate, and there's reasons. We don't have to just believe in a future. We just know we want to be healthy. So there might be a difference there. That's interesting. 'Cause I don't think I've really come across that in the literature. They do tend to try and. Well, the thing is, the people who believe in it want to write about it as if it is this unifying concept. And then the people who don't believe in it probably don't write about it very much. Now, I think there's an interesting question. Are there not just different types of social capital in the sense of individual, community, cognitive, structural, but are there different types of social capital in different sectors of the economy? It's interesting. Any more comments? Questions? Well, let me just give you a sense of where this goes now. So on Monday morning, I'm going to talk about some of the health economic evidence and studies. Essentially, they've used some of these measures and then have tried to relate these measures to changes in health. And a key feature for health economists and indeed economists is the issue of causality. To what extent does a change in one thing cause a change elsewhere? So to what extent does some change in social capital cause a change in health? And the argument that health economists would make is they've been particularly concerned about that, whereas quite a large part of the social capital literature has been more looking at associations. And as you'll know, when you do any sort of empirical work, there's a very big difference between an association and a relationship which is causal. And it's extremely difficult to establish causal relationships. But of course, they're the ones that matter. If we then come to think about policy and think about what sort of changes we might implement, you implement a change, you introduce a policy because you anticipate it's going to have an effect, because you think it has a causal relationship. So for example, you might introduce policies which encourage the growth of social capital. And you're doing that because you think social capital increasing will cause other beneficial outcomes. For example, improved health outcomes. So this association causality aspect is really important. And so I'll be talking a bit about that on Monday. Okay, well, is it legitimate to stop at this point? I don't want to shortchange you, but it's quite warm now, isn't it? And I do appreciate that while you've all got good command of English, it's always difficult to listen to a new voice, and it's just difficult to listen to anybody for an hour and a half, whatever language they're talking. So congratulations to you for surviving. Now, enjoy your weekend, and I hope to see you on Monday. Please. Thank you.